Okay, hello everyone. I'm sorry for this delay. I thought we'll wait for 10 minutes for this to join. For those who I think woke up a little bit late, still there are a few candidates who haven't joined, but let's start. It's their decision. Let's start with our session today. So these are the topics that we are going to cover today. I'll try to make the maximum out of these. I hope so we'll be able to cover in 2.5 hours time, slightly. Let's start with our first topic. So if you just have a look over here, transgender or homosexual, these two different type of domains need to be covered up almost in the same way, not in terms of history is different, but management or the things that they expect from us in the general practice, they are the same. So why do they give us transgender and homosexual cases in the exam? Because they want us to learn how to behave when we see a patient who is a homosexual or is a transgender. They want us to stay calm, not show any odd expressions, be kind towards them, give them some support, find out if this patient has been undergoing any sort of harassment, bullying, or has a low mood, or if he has any difficulties, any challenges in the environment, in his surroundings. So that's the purpose of giving these cases. So even if you have a look at this overall, talking about, let's suppose, UTI transgender, why do they give us UTI transgender? So that if a patient comes to us with UTI or any chest pain, but he's a transgender, it's not only not only about making a diagnosis, it's also about seeing if this patient is having any other challenges at all. Okay, so UTI, they do give us UTI in normal, not normal, I mean, the transgender is also a normal person. So they do give us UTI in a female or a male as well. They do give us this chest pain in a male or female as well. Okay, they do give us bullying or domestic violence in a person who is not homosexual as well. But the purpose of giving these stations in this way is just that we should ourselves inquire the patient if he has any mood issues, if he has any type of problems that he's facing in the community. Okay, so it's very, very important for us to identify any mood issues, any bullying at any place, at workplace, at home, or out in the friends, or any type of mood issues that the patient is having. Okay, let's start with our first case. So the first case is gender dysphoria. What actually gender dysphoria is? It's a condition in which the patient is really distressed and he feels that his body lies in a different soul, or he desires to be of another gender as compared to what he actually, the gender that he actually has. So when it comes to this type of a situation, this patient coming to us, where you are FY2 working in a GP surgery, who the patient is Tom Cooper, is a 15 years old boy who has made an appointment to come to see you. Other information is none. What you must do, talk to the patient and address his concerns. See, no treatment is here. It's just about addressing his concerns. So you go in, you greet the patient according to your grips, then you start asking the patient, how may I help you? The patient tells you that, doctor, I want to change my gender. All right, so he's 15 and he wants to change his gender. All right, so can you tell me a bit more about it? So we should not be overreacting to the sentence that I want to change my, don't say, oh, okay, nothing like that, okay? So that is happening sometimes with the candidates when I take mock, but please do not act that way. Be very neutral, be very normal when you go on to ask these questions. I want to change my gender. All right, I think I'll be able to help you with that. Can you tell me a bit more about it? Yes, doctor, I've been feeling like a boy. For example, if it's a girl, she might be saying that I've been feeling like a boy, and if it's a boy, saying that I've been feeling like a girl. So don't be scripted. Anything can come in any way. Don't think of what has been coming in the past scenarios, because if you will start thinking on those lines, you'll even forget that whether you're talking to a boy or to a girl. So if the patient sitting in front of you is a female and she says that she wants to become a boy, all right, can you tell me more about it? Yes, doctor. I just want to look like a boy, feel like a boy, act like a boy. All right, since when have you been feeling this? Have you, do you think that you have these feelings all the time, or does it change? Sometimes you're okay with being a girl and sometimes you want to become a boy. Okay, apart from this, have you had any other changed feelings at all? Is it only a feeling, or have you already started living as a boy? No, doctor, I've not started living as a boy. Or yes, doctor, I've started living as a boy. Can you tell me what things have you changed in your life? I've started wearing boys' shoes, boys' clothes, and sitting and standing up with boys. I'm mixing up with boys and stuff like that. She'll tell you stuff like that, and then okay, if that is the case, have you ever sought any help or joined any support groups at all up till now? Yes or no, doctor? Have you disclosed this to anyone? I mean, at your home? Might say that yes, I have, or might say that no, I have not disclosed. I'm afraid they will not accept it. My mother will not accept it. My father will not accept it. All right, so you keep going. You need to ask all these questions. Come what may, you are not supposed to miss any questions. Actually, ask about acceptance at home, acceptance at school, acceptance in the community. So ask him that, have you talked to anyone in your school? If he says yes, then ask him further. If he says no, then you don't have any other thing to say in an answer to no to all these questions. If he says, keep saying yes, keep asking him that, okay, and have you had any challenges at school? Have you had any problems at school because of this feeling? And do you have any friends? Yes, doctor. Have you shared with them? Yes or no? Okay. So if he says that he has been facing any challenges, even if not, ask him, how has your mood been recently? My mood has been okay. Can you scale your mood on can you grade your mood on a scale of 1 to 10, 1 being the minimum and 10 being the maximum, the high mood? All right, it's around 6 or 7. It means it's normal mood. All right, are you able to sleep and eat well? Yes, doctor. By any chance, has this affected your studies at all? Because he's a student, so you'll be asking about studies. Yes or no. If it has affected his studies, then definitely you need to counsel him. Going on next, these are the only questions that you need to ask. So after going to Meftosa, any medical conditions, any medications, allergies, you don't need to ask allergies and stuff. Just ask a few questions about medical conditions and medications. Do you smoke? Do you drink? And how has your diet been recently since you've been in this, having these feelings and stuff? You're done with your history. Ideas, concerns, and expectations. Very, very important. Do you have any particular concerns today? Is there something really bothering you? Yes or no? Then you go on to ask about expectations. Do you particularly expect anything from us today? The patient says yes or no, whatever he says. Okay. If he says yes, I expect if you can refer me to some place where I can have this change. All right, that I think I'll be able to help you with that. So coming on to examination, as a part of our consultation, we always are going to do an examination. Examination includes nothing but just observations. That's more than enough. Once you've done the observations, you go on to your management part. Thanks for coming in today. Well, this feeling of being in a different soul, or this distress that you have because you think you have a different gender, it is something we call as gender dysphoria. Okay, it is something we call as gender dysphoria. You explain that to the patient. Okay, But do not worry. It's a feeling that anybody can have, and you should not be feeling bad about it. As you came in to gain some support from us, yes, I'm sure I'll be able to help you with that. I'll give you a referral to the CAMHS, that is Child and Adolescent Mental Health Services. You can write it down. Child and Adolescent Mental Health Services. Okay? Any child who is below 17 years, you can send them to CAMHS. Any child who is above 17, you can maybe directly send them to Gender Identity Clinic. So what will happen in CAMHS, because many of these children at this age, he is 15 years old and he's having these feelings, it usually takes some time for them to have a fixed feeling. What do I mean by this? Many a times, this child who has come to me today, he might go back and start thinking, oh, I'm okay being a girl. I do not want to become a boy. So they are confused. There's a time period for which they remain confused. Just swinging between being a girl or a boy, all right? They are confused every day. Okay, what do I want to look like or be like or behave like or live like? So what happens in CAMHS, because it's a mental health service, they are going to assess his situation, and then they are going to decide whether he needs to go to the Gender Identity Clinic or not, and then he will send him to the Gender Identity Clinic if needed. So what's your job today? You are going to send this child to CAMHS. Any child who is above 17, that also you can send him to CAMHS, but he will be quite quickly referred to Gender Identity Clinic once he is in the CAMHS. Then as a support, please do provide him with some leaflets about his situation. Refer him to the support groups like LGBT. That's a lesbian and gay service, and that also deals with transgender cases. Okay, so transgender and lesbian and gays, all of them go to this. So it's LGBT. I think lesbian, gays, bisexual, and transgender. I think it's for all of them. So I mean, I'm sure that you have to send him to LGBT, but I'm just talking about the mnemonic that most likely it's this is the mnemonic, if I'm recalling rightly. So you send this patient to LGBT for support, and you give him the red flags that if ever you feel that you have a low mood, if you feel that you are being bullied by anyone, if you think that you are uncomfortable with people around you, or people are talking about you or something like that, or are calling names, please do come back to us. We have a lot of support for you. We are always here to help you out. Encourage him to talk to his parents about his situation, even if he says that they are never going to accept, they are going to be very angry and stuff like that. Tell him that, yeah, it's normal for the parents as well, because they do not expect that to happen. So it takes some time for them to accept this thing. This is how you're going to deal with this gender identity case where the patient has gender dysphoria. Going to our next one, this is UTI transgender. It's a very, very simple case. Many times we do get confused how to deal with it, how to go on about it. So what you need to do here in your UTI transgender case, where you are FY2 working in the GP, who the patient is, 20 years old patient Michelle Mason has come to you for some urinary symptoms. Other information about the patient is none. What you must do, talk to her and do further management. So this case is very famous as this Michelle Mason. So what I want to tell you is that please do not be confused with the names. Always remember that whenever we go into a consultation, what's the purpose of confirming the names? The purpose of confirming the names is that we are talking to the right patient, right? So when we ask the patient that, may I know your name and age? And if she says, instead of Michelle Mason, if she says that, doctor, I'm Peter, or I'm Jack, or I'm John, it means that maybe you are talking to a wrong person, right? You do not know from the beginning, because when you go in, it's a girl who is sitting inside. But when you talk to her, she says that I'm Peter. So what is it? Maybe you are talking to a wrong person. If she is looking like a girl and calling herself as Peter, you might think of it to be a gender dysphoria case, transgender case. So you are still going to confirm. Please remember, this is how you're going to proceed in this case. So I'll tell you. Hello, I'm Dr. XYZ, one of the doctors working in this practice today. May I please confirm your name and age? Well, doctor, you can call me Peter, and I'm 20 years old. All right, Peter. Well, Peter, in my notes, I can see that your name has been written as Michelle Mason. There might be some mistake. Oh, no, doctor. Actually, I am on the way to my gender change. That's the reason. That's my biological name, or that's my birth name, or not biological name, sorry, birth name, and blah, blah, blah. All right, that's fine. So you go, how may I help you, Peter? So you start taking history from Peter in a very normal way. Leaves that case there, that he is a transgender. You are going to come to that later. Start taking your history. How may I help you? Doctor, I've been having some problem in passing urine, or maybe have been problem in pain during passing urine. So now in this case, many candidates, what they do is that because they are scripted, they are not taking an adequate history, so they struggle with this case. Whereas it's very simple. When you will try to find out the causes of UTI, the risk factors for UTI, you will yourself reach the cause of having a UTI in this case. So how? Can you tell me more about this pain during passing urine? When did it start? Is it for the first time? Does it go anywhere? Anything makes it better? Anything that makes it worse? And then apart from this pain, any other symptoms at all? Any burning? Any rashes down below? Have you noticed any change in the color of your urine? Any blood in your urine? Any smell in your urine? Now your red flags? Any tummy pain? Any back pain? Any fevers? You're done with your history. Now you are going to the risk factor for developing UTI. So, Peter, there can be some risk factors. So I would like to ask you further questions. That do you need to hold urine for long periods of time? Yes, doctor. Is there any cause? So it's not that you are asking him because you know the case. You are asking the risk factors. What are the risk factors? Holding urine for long periods of time can encourage bacterial infection. Then drinking less water sometimes can encourage bacterial infection. In females, swiping from back to front can encourage. Wearing tight clothing can encourage bacterial infection. So you just ask these risk factors, and the patient tells you that, doctor, I need to hold the urine for long periods of time because I'm uncomfortable going to female toilets as well as male toilets. Female toilets, she doesn't want to go because she doesn't want to feel like a female, and male toilets, she doesn't want to go because she'll be bullied because she still is looking like a female. So once you've taken this much history, you want to ask a few questions about her condition. So have you ever been diagnosed with any medical conditions in the past? Yes or no? Okay, and Peter, are you taking any types of medications? No, doctor. Any medications for changing your gender at all? No, doctor. Any surgeries for changing gender? No, doctor. You keep going on. Ask her about any allergies. Ask her about any mood issues, smoking, nutrition, alcohol. Nutrition, physical activity you can skip, but smoking, alcohol is very, very important, because these young people, when they are undergoing such states of changing their gender or are homosexuals, when they are bullied in the community, then they drink and smoke a lot more. So you definitely need to look into that cause. So ask about smoking, nutrition, smoking, alcohol, and then go on to ask her about her mood. How have you been coping with that? Do you have enough support around? Have you joined any support groups? That's all. Don't go into further details of this transgender stuff in the UTI case. Go to your examination. In the examination, do your observations, because temperature is very important for you here. Then after observations, yeah, that's it. If you want to do at the max, you can do a tummy examination, because this patient has been holding urine for long periods of time and you do not want to think of any retention. Okay. If she has not given the history, then you don't need to do that as well. Then you go on to your management part. Thanks for coming in here today, Peter. And you seem to be having a urinary tract infection. And most likely the cause is holding urine for long periods of time. So I highly advise you not to hold urine for long periods of time. Instead, try to use some unisex toilets, or you can go to the toilet before leaving home, or whenever you feel that you are comfortable, try to use any toilet. Okay, but definitely your comfort is very, very important as well. Then you go on to tell her the treatment. So Qasim RRR, tell her that I'll send for some investigations. You can send for culture if you want to, but in females, because biologically she's still a female, no surgery or nothing has been done. So you just can go on with the female UTI approach. Give her treatment for 3 days. Ask her not to swipe from back to front, not to wear tight clothing and stuff like that. That's all about this UTI case. Give her the red flags. If you have any back pain, any fevers, anything like that, please do come back to us in future. If you ever feel that you are having challenges in the community, see, now you are actually dealing with 2 cases, the transgender and the UTI. It means that any patient who is coming to you with any problem and is a transgender, then you need to ask these few questions and also give safety netting according to them. So if you ever have a low mood, or if you feel that you are having any challenges in the community because of your gender change, please do come back to us. We have a lot of support. Give her some leaflets about UTI, causes of UTI, and also about LGBT. I mean, send her to LGBT if she has not already gone there. That's about this UTI transgender case. Let's go to the next one. Chest pain transgender. You are referred to working in A&E. Shanella Oliver, 28 years old, has come to the hospital with chest pain. He's under transition from male to female. Other information about the patient is none. Talk to her and address her concerns. All right, so this patient, when comes to you, he is under a transition from male to female. You start taking the history. He's in A&E. So you know that you are supposed to skip many, many questions in the A&E. No DESA, no nothing at all. In this very patient, you may not ask about mood and stuff as well, because you first want to deal with the emergency. So now they have given us this case very beautifully. Having a look at this case, this is a UTI coming in the GP. You can inquire about his mood and bullying and challenges in the community. In this one, he's coming in the hospital. He's coming to the A&E. Please do not start taking a detailed history. Start with your history. How may I help you? Doctor, I've been having this chest pain. All right, can you tell me more about this pain? Do the Socrates questions. Once done, you rule out your differentials. The type of pain that he has, sometimes he says it's increased on breathing in, or sometimes he says that it's just here at a particular place. It's increasing with the passage of time. And then when you go on to rule out your differentials, the type of chest pain is not crushing in nature. It started suddenly. The patient also noticed some swelling in the leg when you asked him. So have you noticed any swelling in the legs? Yes, doctor. Have you traveled anywhere recently? Have you been using any medications at all? You ask all those questions to the patient. When you come on to your meftosa, have you been diagnosed with any medical conditions in the past? No, doctor. Have you been using any medications? Yes, doctor. I'm undergoing gender change and I've been using estrogen. Any other medications at all? No, doctor. All right. Since when have you been using estrogen? It has been some time now. He'll give you a time period. And was that prescribed by someone? No, doctor. I just bought it. Sometimes he says that yes, it has been prescribed and I doubled the dose. Sometimes he might say, he can say anything. So do not be scripted that why did he say this and why didn't he say that. Anyways, he's taking estrogen, and that is the most likely cause of DVT in his case, and then leading to pulmonary embolism. So you take a good history, you take good meftosa, you ask him, do you have any allergies, because you have to give a medication, and no need of family history. no need. Travel history you've already asked in the earlier part, and then no need of smoking, nutrition, alcohol and stuff. Do not go into a lots of details here. Ask him that, do you have an idea what's the cause of this chest pain? No, doctor. Any particular concerns? Doctor, it's just increasing with the passage of time, and I do have some difficulty in breathing as well. All right, I can see that you're really concerned about it. So I'll just quickly check your vitals now. Okay, do a chest examination for you. So you do the examination. The examination is going to be normal, whereas the vitals, they are also going to be normal. Sometimes they can be with tachycardia. Okay, that is one of the most common ones. And the ECG can sometimes be, many times, be completely normal. So tachycardia is an important thing that you do need to pick up in these cases. That is the most common presentation. Once you've done an examination, the oxygen saturation is low, you are going to start your management immediately. So now you are into your management. You will tell the patient that you seem to be having a condition, your Qasim RRR, please. For those who were not present yesterday, let me repeat that. There's a mnemonic that I made for the management of cases in our exam. That is CASIM and triple R's. Don't worry, I'll repeat it later as well. Do not unmute your mics. CASIM. C is for condition. So first of all, you tell the patient about the condition. A is for admission or referral. So you tell the patient whether he needs an admission or referral or not. S is for seniors. I is for investigations. M is for management. R is for red flags. Second R is for review, and third R is for reading material. Reading material, your leaflets. Okay, so starting with your Qasim RRR, it's what was his name? Mr. Oliver. Thanks for coming in today. From the information that you've given me and from the examination that I did on you, I found that there's some swelling in your left leg, and you've been having this chest pain and difficulty in breathing as well. And I checked your oxygen level, which is low. It seems that you have a condition called pulmonary embolism. Do you have an idea what that is? No, doctor. The medication that you've been taking for gender change, the estrogen, that sometimes puts us at risk of developing clots in the legs, and these clots can move to our lungs, causing these symptoms. You can say it in this way, or you can say it in any other way, whatever you feel comfortable with. You do not have to copy everything or write everything and say the same. You can say that sometimes it leads to formation of clots in the lungs and legs. Just say like that. And when that happens, then patients have symptoms like yours. So now we need to admit you. So look at Qasim RRR. So now we need to admit you. I'll talk to my senior cardiologist. We will send for some investigations, some special blood tests like D-dimers and all the baseline investigations. We will also do some special scans for you and jelly scan of your heart as well. All right. So you're doing all these. You've already done an ECG for this patient, okay, in your examination part. That is the part of your examination, the ECG. So you have done CASI and now management. I'll give you some oxygen. Do you have any smoker's cough? No, doctor. Give him oxygen. Then give him a painkiller because he has pain. Involve your senior. Let your senior be here. Do not talk about heparin and stuff. And you can tell him that once the senior is here, I'm sorry, he might consider giving you some blood thinning medications to dissolve the clots in your legs and lungs. How does that sound to you? Do you want to call anybody to be with you at the moment? Are you okay with this? Any questions? Any queries? Okay. Since you're in the hospital, if you have any worsening of symptoms, any increase in your shortness of breath or chest pain or any new symptoms developing, please ring this bell. One of the staff members will be with you. Okay. So this is about your chest pain transgender case. Going to the next one. Workplace bullying. Well, workplace bullying in school, It can be a bullying anywhere. It can be with anyone. Don't be scripted, please. Don't think of it as a case of workplace bullying. Take it as a general case. Whenever a person comes to you, there are certain age groups or certain specific people who are at risk of bullying. Who are they? Small children, risk of bullying in the school; elderly, risk of being having violence, domestic violence, and bullying at home. Okay, those who are dependent on others, especially, they are at risk of bullying and violence. And secondly, who stand out differently in the community, who have started getting a bit of identity in the community, they are the ones who are at risk. Okay, so anyone who is coming to you with that, as we've already talked earlier, the transgender cases, we always need to look for mood and stuff and see what's going on with these people. All right, whenever they are coming to our general practice for any problem, we always need to look into this stuff. So this patient who is coming to you with workplace bullying, when she comes in, she might say something from the beginning, but in our case that has been coming recently, the patient is actually looking down, not making a good eye contact. And if you'll be a good doctor, try to ask the patient in a good way. Do not throw your confidentiality every now and then. Throwing the confidentiality 10 times in a consultation means that you did not make the patient comfortable enough from the beginning that he or she opens up to you. Believe me, confidentiality is not a sentence that needs to be made in every such consultation. Confidentiality is needed when your patient is feeling uncomfortable and he thinks that you might talk to someone else. So if you will make him feel that you are not going to talk to anyone else, or if you make him feel that, make him feel comfortable, make him feel that he's in a safe place, make him feel that you are the one who is going to help him, you won't need to put in the confidentiality statement, believe me. So you go in, you greet the patient, introduce yourself, how may I help you? You see that the patient is looking down, is not making a good eye contact. How may I help you? The patient might say that, doctor, I've been having some fast racing of the heart recently. I've not been feeling normal like before. Sometimes he does not say anything and is just looking down, and you do know that there's something wrong with this lady. So you start taking your history. So how can I help you, doctor? Well, I've been having this fast racing of the heart recently. Can you tell me more about it? Since when? It has been happening for the past 6 to 8 months. All right. And is it continuously there? Have you had any shortness of breath as well? It comes and goes. She says it comes and goes. From the beginning, she might say that it happens only when I go to my work. So when somebody says that I have a headache only when I go to my work, it means that there's something wrong at the workplace. If she says that I only have fast racing of the heart when I go to work, it means there is something wrong at the workplace. So headache is a sign of stress. Fast racing of the heart at workplace only is a sign of anxiety. Rule out your anxiety here. Okay, so if a patient herself or himself tells you that this symptom is related to a specific place, always go into the details of this place. Okay, so if he says that, doctor, it happens only at my workplace, all right, can you tell me more about this? Since when has it been happening? It has been happening for the past 6 to 8 months. Does it happen every time when you go there? Can you think of any particular cause why it happens when you go at your workplace? And things like that. Then she'll tell you that, doctor, she might tell you that, doctor, I've got some new people in the workplace and I've been having trouble because they're looking at me and then talking about me. All right, please do not worry. I'm here to help you out, and I'm sure that I'll be able to help you out with that. Can you tell me more about it? So you need to keep reassuring her and ask her, can you tell me more about it? Well, doctor, actually, I'm in a relationship with a female. So she's a female and she's in a relationship with a female. Or she might directly tell you that I'm a lesbian. So that's the reason they have, since they came to know about me being a lesbian, they started talking about me. All right. So now here, it might be the feeling of this girl that they are talking about her. So we need to clarify the situation. Okay. So do they talk about you every time? Have you heard that what they are talking about you? And have you talked about this situation to anyone at your home or at your workplace? Okay. So she might tell you yes, or she might tell you no. Have you talked to your manager about it? That's more than enough about this. Then you go on to rule out what type of bullying is it. Can you tell me, apart from talking, is there anything else that they do? Like what? I mean, any sexual harassment? No, doctor. I mean, any sort of physical harassment? No, doctor. All right. Any type of violence at all? No, doctor. All right. So apart from this, you do not have any other issues, right? At the workplace, and your work is going fine. Is your work being affected because of this? Is your mood being affected because of this? Is your relationship with your partner being affected because of this? Ask all these questions. Then you go on to your maftosa history. Have you been diagnosed with any medical conditions in the past? Any medications that you're taking? She has already told you about her partner. Since when have you been with her? Are you in a stable relationship? Are you using any protection? Stuff like that. Okay. So she's a female with a female, no protection. Just these questions. Then you go on to your eyes. Do you have an idea what could be the cause? Any particular concerns? Any particular expectations that you think that I can help you with? You ask these questions, then you go on to your examination as a part of your consultation. Uh, Mood, sorry, did I miss on the mood? The most important thing. Has it affected your mood? Ask all the questions of anxiety and mood. That is very, very important. That is the core of the station, actually. So irritability, fatigue, fast racing of the heart, uh, feeling as if there's an impending doom, and then having these situations, these feelings only in a particular place, having a low mood, effect on food intake, effect on weight, effect on sleep, effect on relationships. These are all very, very important. So it's not that you have to put in all these, but you bring in a few points out of these. If she says my mood is okay, then you go on. All right. And have you ever felt that life is not worth living? No, doctor, go on. Don't go into more details of mood then. Whenever a patient says my mood is okay. After that, you go on to your management part. In the management, it's very, very important that you reassure her after telling her the diagnosis. You seem to be having some anxiety because of your workplace problem. That's basically bullying. And no type of workplace harassment or bullying is acceptable in the UK. Tell her that it's not acceptable. The law, there's a law that protects you. I understand that you are in a relationship with a female, but you have a complete right to be in a relationship with whomever you want. This is according to the law. Tell him that since you've been feeling low, you've been feeling this fast racing of the heart, I would advise you to do some relaxing therapies like yoga and meditation. If you feel that your sleep is affected, if she says that her sleep is affected, give her some sleep hygiene techniques in the written form. Then you go on to tell her about LGBT Foundation or the support groups like Broken Rainbow. These are the two support groups that you can talk to her about. As I said earlier, LGBT is for both homosexuals and for transgenders. Then you give her a solution to her problem. Ask her to talk to her manager if she still has not talked, because it's the duty of her manager to take certain steps. If he does not take any steps, then she can go to employment tribunals, who also always look into the matters in detail. So first manager, and then employment tribunals. Then you can send her for CBT if you think that she needs. Always give her the management according to the symptoms she has. If she has fast racing of the heart that is only there at the workplace, send her for talk therapy, because it will help her help her in her situation. The talk therapy is going to help her in a way that the therapist will help her cope with the situation whenever she goes to her workplace, whenever she come across those specific people. Give her support, give her red flags in the form of mood, give her red flags in the form of any fast racing of the heart along with chest pain if she has. That's the way you're going to end up this case. Always review these patients, always. All the ones that we've just read, always review them, because he is undergoing something continuously on a daily basis. So yes, you want to review her. Review her after 2 weeks time. Tell her that let's meet again after 2 weeks time, just to see that how everything is for you now. Okay. Yeah, that's all about this gender dysphoria, workplace bullying case. All right. Low mood miscarriage. So now we have actually moved to the psychiatry cases. Okay. Low mood miscarriage. After this one, we'll have a short break of maybe 5 to 7 minutes. Where you are FY2. Where you are FY2 working in a GP. Who the patient is, 30 years old female Lisa, has booked an appointment with you over the phone. The information is none. What you must do, talk to her, assess and manage the patient. When you go in, you say hello on the phone. Always follow your telephonic consultations protocol. You always need to give your identity. Hello, I'm Dr. XYZ, speaking from the GP clinic. Can I please confirm your name and age? I'm Lisa. I'm 30 years old. All right, Lisa. May I know? May I please know your address? Confirm her address and postbox which has been given to you inside the cubicle. She confirms her address and asks her, are you in a comfortable place to talk at the moment? Even if she is the one who has booked an appointment, it's completely okay. Ask her. Tell her that I'm going to talk for about 8 to 10 minutes. Are you in a comfortable place? Yes, doctor. And in case if the call drops, is it all right if I call you on the same number? That's fine, doctor. Once you have done this, carried out this protocol, you go on to ask her, how may I help you? Doctor, I've been feeling very low. All right. Can you tell me more about this? Doctor, I've been feeling very low for the past about 2 months or 1 month. All right. And is your mood continuously low? Yes, doctor. Apart from, on a scale of 1 to 10, how would you grade it? It's around 2 or 3, doctor. All right. I'm really sorry. That's a really low mood. Apart from this low mood, have you had any other symptoms? Yes, doctor. I just don't feel like going out with my friends or meeting people. My work is being affected. All right. I can see that it is really impacting you a lot. Can you tell me, has it affected your sleep? Yes, doctor. Has it affected your work? Yes, doctor. Has it affected your weight or appetite? Any changes in your weight or appetite? No, doctor, it's all fine. Or yes, doctor, it has decreased or increased. She can say anything. So you are the one who is going to identify whether this is depression or not on the basis of your knowledge, right? So when you've done that much, you go on to a little bit more detail, because this is a mood issue. So ask her, have you had any feelings of guilt at all? Yes or no, doctor? All right, apart from all this, have you ever felt that life is not worth living? This is how I always want to go into the depression history. After asking about low mood, whether this patient is meeting up with friends or family or not, asking a change in appetite, appetite, weight, and sleep. Have you noticed any changes in that? Go to the guilt, go to effect on life. Then you go on to ask this patient that, have you ever felt that life is not worth living? Yes or no? Then you go and ask her that sometimes when we have a low mood, we feel like hurting others or hurting ourselves. Have you ever felt like that? Yes or no, doctor? Go on to ask her one more question from the psychiatric section. ask her that sometimes we normalized the question by saying that sometimes when we have a low mood, we feel that we feel like hurting ourselves or hurting others. So in the same way, ask her, sometimes when we have a low mood, we see or hear things which others don't see or hear. Has that ever happened with you? No, doctor. All right, so no more of your psychiatric history. Just close it here. You do not need any more of that. You ask her that any other symptoms at all, any fast racing of the heart, any shortness of breath, any problems at all. Before all this happens, ask her that,
The voice.
Can't hear you, Dr. Noor.
The voice.
hello, it's back now. I'm really sorry. Thanks a lot for letting me know. I think it's back now. Can you just unmute yourself and tell me once that are you able to hear me
Yes,
now?
can hear you
Can you
now.
hear me now? Okay. Okay, great. Thank you.
Hello, sir.
Okay, so I'll repeat a little bit. So you've taken the history of low mood. After that, to rule out if she has any psychiatric issue as well, you do ask her about hallucinations by normalizing your question by saying that sometimes when we have a low mood, we see or hear things which others don't do. Have you ever had that? No, doctor, I've never had that. All right, you ask some physical symptoms of all this, like any shortness of breath or any fast racing of the heart. No, doctor. And then you want to ask her that when it started about 2 months back, at that time, any particular thing happened. Doctor, my partner had a miscarriage. So she's a female and she's telling you that her partner had a miscarriage. So now you already know that she has a female partner. All right, they must have undergone some process to have this baby. Definitely, that's a very distressing and depressing situation for her. This is very normal for her to have this. So this depression, I mean. Then you want to ask, I'm really sorry to hear about your partner. How is your partner doing? Is she fine? Yes, doctor, she's fine. Does she have any mood issues at all? No, doctor. Just ask 2 to 3 questions around that. It must have been really distressing for you because it takes some time to get pregnant in your situation. Yes, doctor. Then you go on to ask her that her own history. Okay, don't go into the details of the partner now, because that's all you needed to know. All right, not lots of details of this. Then you go on to your meftosa. Ask her, have you been diagnosed with any medical conditions in the past, any medications, any allergies? Do you have an idea what's going on? Sorry, smoking, nutrition, smoking and alcohol as well. No nutrition and diet, just smoking and alcohol. Then go on to ask her ICE questions, ideas, concerns, and expectations. Tell her that since we are over the phone and I'm unable to, if you were in front of me, ideally I would have done an examination on you, but since we are over the phone, I'll tell you what's going on. So it means that the examination is not that important at the moment. Okay, so you tell her that I'll tell you what's going on. You seem to be having moderate depression because she doesn't have any suicidal thoughts, but her life is being affected. So this is moderate depression. How do we differentiate between mild, moderate, and severe depression? I'll tell you that as well. In mild depression, patient does have a little bit of low mood, and her or his weight, appetite, sleep, usually they are not much disturbed. Life is not affected. Okay, in moderate depression, life is affected. Okay, in moderate and severe depression, life is affected. Their job can be affected because of their low mood and stuff like that. But there are no suicidal thoughts in usually in moderate depression. And then in severe depression, there will be suicidal thoughts. There will be thoughts of harming others. They can be some past history of suicidal attempts as well. They can be a family history as well. There can be many things in the history. Okay, so just roughly, in order to differentiate between the two, this is between the three, this is the way how you can. So this patient doesn't have any suicidal thoughts and stuff like that. She has moderate depression. So you start her on medication. You start her on medication. Tell her that you seem to be having a depression. This low mood is something we call as depression, and it can be due to some chemical imbalance in the brain. Sometimes when things like the way you had to face the situation, sometimes that can lead to depression. What we can do for you now is that I can talk to my senior. We also need to send for some investigations for you. For that, I would want you to book an appointment, a face-to-face appointment with us, and I can. So there are two ways to do it. I'll tell you about the appointment, what you need to do, but let me tell you the management first. So you tell her, the management, that I'm going to give you an antidepressant. This antidepressant will help normalize the chemicals in your brain. Usually it takes 2 to 6 weeks to start its action. So please do not stop the medication in between. Sometimes patients who start taking this medication can have some side effects like inability to sleep, or sometimes they can have a tummy pain or nausea, vomiting. If something like that happens, please get in touch with me again over the phone. Give her red flags. If you ever have thoughts of harming yourself or harming others, please do come to us as soon as possible, or do go to the nearest emergency. So any red flags, send them to the emergency. Any patient, any red flags, send them to the emergency. If you have any thoughts of harming yourself or harming others, please go to the nearest emergency department as soon as possible. Just like that, you end this case and review this patient. You always have to review these patients who have mood issues. May it be a transgender case, may it be a homosexual case, may it be a mood case, may it be a psychosis. But psychosis is going to be sent to the hospital, so not that. But all these other cases, you always need to review the ones that you are sending home. All right. So this is about our case up till now. Let's take a break for 5 minutes. I'll have some water. You guys also just rest for 5 minutes, take some water or something, a cup of tea maybe, and then we'll catch up after 5 minutes, 5 to 7 minutes. All right?
Yes, thank you.
Okay, let's start then. Let's restart our session so that we do finish in time as well. All right, so starting with psychosis. I think all of us are here. Yeah, all 33 are in call. So this is psychosis telephonic. All right. So what is this case? Well, not this case. Generally, anybody? Okay. So about the previous case, there was one thing that I just said that I'll tell you in the end. So if it's a telephonic call and you diagnose someone with any problem, any telephonic call, because of COVID, you very frequently need to take telephonic calls in the GP and in the hospital setup in the Western world. Whenever you have a telephonic call and you think that you do not actually need to do a physical examination for this patient, which requires a face-to-face consultation. So if you do not need to do a physical examination, but you want to do some blood tests for this patient, then you can give him a form through the NHS email. You can send a prescription, not the prescription form, the lab form through the NHS email. They'll just get their tests done, and then you can narrate the reports over the telephone itself. Right? So this is one thing. So never be confused. Like, for example, in the previous depression case, you do not need to do a physical examination. You can go without that. The cause was very clear cut. The case was very clear cut. So you diagnose that lady with moderate depression. You give her the treatment. You send her for CBT. You give her write the investigations for her. Send her that investigation form through the NHS email. That's what you need to do. Give her red flags. Tell her about the treatment that we've already talked about. So this is how it goes. You only call the telephonic patient to the practice if you think that you need a physical examination to be done. That's a must. If, for example, a physical examination is a must, then only you will call them to the practice. Okay. Otherwise, do not call them. For CBT, you can give her a referral even over the telephone. You do not need to call her to the practice and give her a referral, right? All right, coming to your to the next case, that is psychosis. This has been very confusing for many people recently, because in our part of the world, in the places where we are usually living, not in UK or Australia and places like that, we are often afraid of disclosing the diagnosis to the patient, especially if it's some sort of a mental health problem. We are always afraid of that. But remember that it's not the case here. They welcome you. They might deny the diagnosis. They can deny the diagnosis, but they won't be annoyed over the diagnosis, saying that, do you think that I'm mad? They'll not say that. Okay. So please be comfortable when you have to say the diagnosis. So in this case, overall, the history of psychosis, how do we go about that? You know that you go in, you talk to the patient, you take a history. The patient might from the beginning start saying that my friends, my parents, and blah blah blah, somebody has been feeling that I've got some problem, but I don't know what the problem is, or something like that. Or the patient might come to you with a very high mood. In case of bipolar disorder, a very, very high mood. You might have some hallucinations and thought insertion and stuff like that in case of psychosis. So you go in and start taking your history. So what's the structure of the history that you're going to follow? You are FY2 working in the GP. Call a 24 years old university student has made an appointment over the telephone. What you must do, talk to him, assess his condition and manage him. See, assess his condition. You are going to assess his condition over the phone and manage him as well. Remember that any patient who is at risk to himself or to others definitely needs to go to the hospital. May it be a physical risk or may it be a health risk, whatever type of risk it is, we always send the patient. Like, for example, if a patient is coming with a chest pain, patient is coming with testicular torsion, we always send them to the hospital. Similarly, if it's a case of psychosis or a severe depression where you think that there is some risk to himself or to others around, definitely you need to send him to the hospital. So when you start taking the history of this patient, He says that my mother thinks that I have an issue, but I don't think that I have a problem. All right, can you tell me more about it? Doctor, my mother says that I've been acting weird, but I don't think so. I have an issue. All right, it's okay. I understand that you don't think that you have an issue. What does your mother say? Actually, I've not been sleeping for the past few days. This is sometimes what he says, or sometimes he says that I've been talking to my friends around which who I can see and my mother can't see, something like that. So whatever is the case, you start taking your history. You start taking your history and always take the history around the point that the patient has narrated to you. Please don't go to the other history first. For example, if he says that my mother, I've not been sleeping well. Okay, can you tell me more about your sleep? How many hours every day do you sleep? Doctor, I did not sleep for the past 4 hours, 4 days. All right. And is it for the first time? And how are you doing without sleeping? Are you able to concentrate well on your works or not? Are you able to carry out your daily activities without sleeping at all? Can you tell me a bit more about yourself? Apart from sleep issue, have you had any other problems at all? Like what, doctor? Have you had any mood issues? No, doctor. Any high mood or low mood? No, doctor. I think everything is fine. And since you got the point that this patient is not sleeping well, you are thinking of mania, which is a high mood. You do ask a few questions around that condition, like what? I mean, sometimes when we are not able to sleep every day, there are certain things that can happen. So have you been feeling that your mood is very high? Have you felt that you are able to see or hear things which others can't hear or see? He might tell you about some sort of hallucinations. Whenever it comes to hallucinations, you need to check if he has any command hallucinations as well, because command hallucinations is a red flag sign. Whenever a patient has command hallucinations, after ruling out mood, you have gone to the hallucinations. After mood, go to hallucinations. Okay, take up this sequence of taking the history. Just a moment. See. All right. So you check his mood. Ask a few questions around that. Check for suicidal thoughts and stuff. Then you go on to check his hallucinations. Sometimes when we are feeling high or low, we tend to see or hear things which others don't do. Has that happened to you? Yes or no? Have you ever felt that people are putting thoughts into your mind? Have you ever thought that somebody is taking thoughts out of your mind? Have you ever felt that somebody is following you? So you are asking all your thought questions, your perception questions, hallucinations, mood, everything. Do you think that you need help? No, doctor, I don't think that I need any help. I think I'm perfectly fine. In all this history, what are the red flags? You do take your other history questions as well. I mean, the Meftosa questions or the famish question. Whom do you live with? Do you have family and friends around? Any financial issues at all? Any problems with the law at all? Then you go on to ask him about any drugs, alcohol. Drugs and alcohol are very important because many a times it can be just drug-induced psychosis. So ask all your history, which you already have in your mind. Then you go on to rule out the red flags. What are the red flags in this case? If the patient has any command hallucinations, well, any type of hallucinations, you are going to send him to the hospital. But command hallucinations is a very big red flag. Okay, he might be having a command hallucination that please go and punch people outside, or go and kill them, go and take your knife and kill them, things like that. If that is the case, that's a very big red flag. Remember that.
I'm sorry,
Then,
Doctor. I'm sorry. What's the commands hallucination? I did not get.
okay, please ask in the end, Dr. Bola. Do not unmute yourself. I'll say it again now. Right? Command hallucinations are the any questions that you have. We do have a slot in the end that we ask about everything, but I'll clarify it now. Command hallucinations is, as I just said, that the patient hallucinates that somebody is commanding him to do something. Someone is commanding him to go and kill the other person or punch the other person on his face. Okay, so these are command hallucinations. Whenever he tells you about command hallucinations, you can always ask him, have you ever followed the command at all? No, doctor, I did not follow the command. That's really very good. Appreciate him. You go on to take your further history. So again, talking about the structure from top to bottom, you check for mood, do the mood history. Okay, you check for hallucinations. You check for thought process, the thought insertion, thought withdrawal, thought broadcasting. If he feels that somebody is following him, those questions, then you start asking, check his insight. Do you think that you need help? Ask him that, do you have any friends around, your family members, any support, any problems at all? What do you do for a living? Have you been drinking more recently? Have you been using any illicit drugs at all these questions we need to ask. Once we come to know that out of all these questions, the positive history is command hallucinations or any hallucinations actually, send him to the hospital. If this patient has thought process issue, if he says that somebody's putting thoughts into my mind, or somebody's withdrawing thoughts out of my mind, or my thoughts are being broadcasted on the TV, something like that, send him to the hospital. If he says that he does have thoughts of harming himself or others, send him to the hospital. Okay, if he's living alone and he has all these symptoms, then that is even a bigger red flag. So you need to check for all these red flags. And if he says that he thinks he does not need help, it means that he does not even have an insight to his condition. Having an insight is very, very important. Okay, so if he doesn't have an insight to his condition, again, you need to send. You've taken a history. You come to the examination part. You tell him that ideally I would have examined you if you were in front of me. But at the moment, Mr. X, I think you are, so you coming to your Qasim RRR, you seem to be having a condition called psychosis. Do you have an idea what that is? Don't worry about saying it. You need to say, I'll tell you in the end today that why we always need to say the diagnosis. Just a moment, let me write it down. Diagnosis, always. So you always need to say the diagnosis, whatever the diagnosis is. Why? There's a reason behind that. If you want to clarify the patient what he's suffering from, it's not a good thing that he goes back home or he goes to the hospital, but he doesn't know that what's the problem. So tell him about his condition. Tell him he needs to be admitted immediately. So you can arrange an ambulance for him. Please, it's clearly written in the NHS that never send a psychotic patient to the hospital alone. Don't ever do that. Always arrange an ambulance or mental health care services to come and pick him up from home. In the meantime, what you can do, you can say him that, okay, let's stay on touch on the phone and keep me updated about your feelings and stuff. Well, doctor, I don't think I need help. I don't think I have a problem. I understand that you're feeling that you do not need any help, Mr. X. But according to what you have told me, sometimes we do have such feelings and we do not have a good insight to understand that we need help. But according to my assessment, according to the questions that I've asked you, I really think you need help. Do not worry if the patient keeps saying that he does not need help. You have to inform the mental health services. He can be detained into the hospital under Mental Health Act. This does not happen in the GMC exam. They do not assess you over this thing. They do not take you that far. But this information I'm giving you just to make you feel confident about what you are doing. Okay? If he says that I don't need help, I'm completely okay, don't say, okay, fine, goodbye. Please never do that. Do not put your patient and his family members and the people around him at risk from him. Always arrange an ambulance. And in the exam, as they're not testing you over that, the patient will say, okay, doctor, that's fine. I'll wait for the ambulance. Okay? That's it. If he ever refuses, what else you can do? You can say that, okay, I'll arrange a meeting with your mom and I'll inform my senior as well. It's very important for you to be in the hospital. So you say your things in any situation. If the patient refuses, you say your things, you speak out your things, what you want to do. All right? Keep in touch with the patient over the telephone. That's about psychosis. What can be the symptoms of psychosis? The patient can have, again, I can repeat once for those who are not very clear about it. The patient can have hallucinations. It can be visual, auditory, it can be sensory, or it can be command hallucinations. Okay. So auditory, the patient is seeing things around him which others don't see. The patient can hear things around him which others can't see. The patient can smell certain things which others can't smell, and the patients can have a command hallucination. Somebody asking him to do certain acts. Like, for example, I'll give you an example of my patient in the general practice that I had. That lady, 55 years old, she had a command hallucination that somebody is asking me to go and eat sugar again and again. She used to eat sugar a lot because she was having those command hallucinations. But see, that's a simple command hallucination. She might destroy her teeth or her blood sugar levels because of that. But that's a command hallucination. That is always a red flag sign. Anybody who is having a command of eating sugar can have a command of punching and killing others as well. So remember that any type of command hallucinations, sent to the hospital. So that's about hallucinations. Coming to the thought, you can just ask three questions, three simple questions. Uh, there are many types of thought issues and thought questions that you can ask in case of a distorted thought process. But the three most easiest ones to remember are that: have you thought insertion, thought withdrawal, and thought broadcasting? So I always prefer telling this to everyone. Have you felt that somebody is putting thoughts into your mind, somebody is taking thoughts out of your mind, or somebody is broadcasting your thoughts onto the multimedia, onto the TV and radio and stuff like that? Have you felt that somebody is following you? After thought insertion, after thought, first of all was hallucination, then thought, then ask him, do you think that you need help? All right. That is very important, because if a patient has a poor insight, then he will never say that he needs help. He will always say that, doctor, I'm fine. Then after this history, you go on to take your famish history, family, friends, forensics and stuff, whatever you want to ask. Then you ask about alcohol, drugs, smoking, all those questions, and then you go on to your management. So I've revised this case twice or thrice now. I hope it's clear. It will help us do the next case as well. That's okay, where did that go? Postpartum psychosis. Okay, let's do this one first. Postpartum psychosis. There you are FI2 working in the GP. Who the patient is, 22 years old Sabrina has booked an appointment to talk to you. She has given birth to a baby boy 7 weeks back. Other information about the patient is none, and what you must do, talk to her, assess her condition, and address her concerns. So this lady who is calling you over the phone, okay, this is a telephonic appointment. So the same protocol of telephonic stations, please, when you are practicing with your friends, try to follow the whole criteria so that you get used to of saying that to your patients in the exam and in the real situation as well. If you won't practice it in the right way, thinking that, okay, in the exam I'll say it, but now for the sake of saving time, let's go ahead. No, practice it fully with an 8 minutes timer or with a 7.5 minutes timer. Practice it fully. That's the best way. So hello, I'm Mr. X. I'm Dr. X speaking from the GP. May I confirm your name and age? Confirm address. Is it the right time to talk? Right number if the call drops. How can I help you? Start taking your history. So this lady wants to talk to you because she is not feeling well. What kind of a problem does she have? Doctor, I'm unable to sleep. She can say that I am unable to sleep. Whenever there's a postpartum lady who has a sleep issue, it can be a very normal presentation, because when we have a baby at house, it's really difficult for moms to sleep, because many times the baby is waking up the whole night. You need to change his nappy, so you want to feed him and do his stuff, and because the baby doesn't have a good circadian rhythm, he's many times waking up the whole night and sleeping in the daytime. So you take a good history. Don't think of postpartum psychosis, please. It might be a normal case. So you need to take a good history. Whenever you take a history, don't think of a case in your mind that you have discussed with your friends. It will make you scripted. Start taking a history. Can you tell me more about your sleep problem? Since when have you had this sleep problem? Doctor, actually, I gave birth to a baby 7 weeks back, and since then I'm having this sleep problem. Oh, congratulations on having your baby. How's the baby? I'm sorry for your sleep problem. Can you tell me a bit more about that? How many hours have you been sleeping recently? Just 2 to 3 hours, maybe, or something like that. Oh, that's really low. And apart from the sleep, and are you able, at what time are you able to sleep? Are you able to sleep in the daytime or not? So you're asking a few questions around sleep. Then you ask her any other problems at all, open-ended question. No, doctor, I do not have any other problems at all. All right, just to make sure everything is fine, I'd like to ask you a few questions. Would that be all right? Yes, doctor. So, have you noticed any recent? So, see, sleep is affected. Have you noticed any changes in your level of concentration in the daytime? Yes, doctor. Have you noticed that you have any problem handling your child? Yes or no problem. Do you have any support at home when you sleep? Have you ever considered asking anyone else to take care of the baby and then you can sleep for a while? Doctor, I'm not able to sleep even if my baby is not around. It's not because of the baby, but I think I'm unable to sleep at all, even when my husband is looking after the baby. Or, oh, okay, so now you got a clue. There's something else going on. So you ask her, all right, have you felt that your mood is low these days? Yes, doctor, my mood is low. Can you tell me a bit more about that? Since when? On a scale of 1 to 10, then you ask her about any changes in her weight, any changes in her appetite, and any feelings of guilt. Feelings of guilt are very common in the postpartum stage in patients who have postpartum depression or postpartum psychosis. They often have very bad feeling of guilt that I think that I'm not able to take care of my baby and stuff like that. So ask her about feelings of guilt. Have you thought of harming yourself or others? So the same history is repeating as we did earlier. Do you think that life is worth living? Have you thought of harming your? Have you had thoughts of harming yourself or others? Sometimes when we have a low mood, we feel we listen or hear to things which others don't do. Have you had any things like that? Yes or no, doctor? Once you've taken a history, you are able to assess whether this patient has a postpartum depression or psychosis. Postpartum depression or psychosis. And if it is depression, then what's the level of depression? Is it mild, moderate, or severe? Because the management is going to depend on the level. Let's discuss the management of all of them. If it's mild depression, you can just see her after 2 weeks in the clinic, ask her to take some help. You have to follow up more quickly, maybe in a week, not after 2 weeks' time. Okay? Ask her to book an appointment, talk to her husband as well, because she has a baby. You do not want to put this baby at any risk. When it comes to moderate depression, again, the same things. Send her for CBT, give her medication, talk to your senior, discuss about the type of medication that you need to give her because she might be feeding her baby. That is in the history that you are going to ask her. Then you give her medication, tell her the side effects, and tell her the effects take about 2 to 4 weeks to happen. If it is severe, you always need to send this patient to the hospital to be admitted in the mother and baby unit. Mother and baby unit. There is a mother and baby unit where the mother will be able to see her baby. The baby won't be kept away from her. She'll be able to feed him. She'll be able to play with him. Mostly it would be supervised so that she may not be able to harm the baby. Coming next, psychosis. Same way. So we were going in a sequence from mild, moderate to severe depression. Now coming to psychosis, same way. You know that psychosis is a condition where you need to send this patient to the hospital. Definitely. You need her to be admitted in the hospital in the mother and baby unit. Definitely. To be seen by a specialist, a psychiatrist. Definitely. So in this case, how is your management going to go? You seem to be having postpartum psychosis. Have you ever heard about that? No, doctor. It's very common in females who have recently delivered a baby within the past 6 weeks or so. Whenever females have this condition, they have thoughts like yours, like thoughts of harming themselves or the baby, whatever thoughts she tells you. When you've come to know that she has some hallucinations, she has command hallucinations they can have of killing their baby. Okay, so that is why command hallucinations are very important. So if you've already taken a good psychiatric history and you've checked for the risks, send this patient to the hospital. So this postpartum psychosis is a condition in which the mothers who have delivered a baby in the last 6 weeks, sometimes they can have these feelings. This is due to the chemical imbalance in your brain that can happen after delivery. But don't worry, it's a manageable condition. But for this, I need to send you to the hospital immediately to be seen by the psychiatrist, and you will be admitted in the mother and baby unit. You will be looked after. You and your baby will be looked after by specialists very regularly. You will be supervised. Okay. Then you send an ambulance to her for this admission. Don't ask her to drive with her baby herself. Then ask her, tell her that in the hospital they might do some tests, they might do some assessment for you. Please let me know, do you have any help at the moment? Is there anybody by your side that I can talk to? So just in a natural way, what would you do if a patient like that one is calling you? This is what you can do, right? You can talk to the dad or the mom of this mother, that they can look after the baby for a while. This patient is not fit enough to take care of the baby. So give some care like that and send an ambulance to pick up this patient from home. Sorry, and send her to the hospital. This is all what we need to do in this postpartum psychosis case. Okay, sorry, I missed one point in the history. When you're taking history, do ask about the baby. How is the baby doing? Are you breastfeeding? Any other problems? Are you seeing your obstetrician or your specialist since you've delivered the baby? Any bleeding issues? Ask her 2 to 3 questions generally as well, because whenever there's a patient at 6 weeks, there's a protocol that needs to be followed, but it's hard to follow it completely in these 7.5 minutes. So ask at least these questions. A couple of questions about the baby, a couple of questions about the mother's other general health, and the remaining is psychosis history. All right, a very, very important topic, a big confusion for many. This is unilateral tinnitus. This is a topic that actually, why is it coming after this psychosis? Because we actually missed it yesterday in our ENT session. So I thought I'll cover it today just before going on to pediatrics. Yes. So let's do this unilateral tinnitus and again take a 5 minutes break because my throat is really getting very dry. So unilateral tinnitus. Remember that whenever there is a unilateral tinnitus, always you need to look into a couple of red flags, which are very, very important for us to know, right? So let's start from the beginning and I'll tell you that red flag in the end. You are FI2 working in the GP, 30 years old male, Cameron, has come in to see you with ringing sensation in the ear. Other information about the patient is none. Talk to him, assess his condition, and manage the patient. So the patient is sitting in front of you. You start taking your history. Can you tell me more? Doctor, I've been having this ringing in the ear. All right. Can you tell me more about this ringing sensation? Or he might say that I've been listening to some sounds in my one ear or something like that. Some ringing or buzzing. He can say anything. There are in the NHS there are given 4, 5, or 6 different descriptions of these sounds. So when you start taking the history, all right, so can you tell me since when have you been having this sensation in your ears? Is it in one ear or both ears? And is it continuously there? Or is there any particular time of the day? Is it getting worse with the passage of time? Anything that makes it better? Anything that makes it worse? The same questions which we always take for any other symptom, the initial questions, the Odipara. Once you've done with that, start asking him the differentials. So coming to the differentials, what can be the possible differentials of having tinnitus in both ears or in unilateral ears. The differentials can be as simple as an ear wax. It can be ear infections, the middle ear infections, and it can be something very serious as an acoustic neuroma. So as always, you are going to take the ear history as we discussed yesterday. 3 things going in, 3 things coming out, and 4 things otherwise. All right. So apart from this ringing in the ears, have you had any pain in your ears? Have you noticed any discharge or any blood coming out of your ears? Have you noticed any wax on your pillow? Now, have you recently used any cotton buds? Have you gone for any swimming activities or any recent air travel? So 3 things going in, 3 things coming out. Now you ask him that apart from this ringing, have you had any fullness in your ear, any hearing problems? I mean, any trouble in hearing at all? Once you've and any head trauma at all. Once you've asked this, have you been exposed to any loud noise? This is something that you can ask exactly in the beginning after taking tinnitus history, or in the end, wherever you feel comfortable, but don't miss that. Because being exposed to loud noise for a long period of time, let's suppose, for example, if somebody is working in the music industry or something like that, it can be a very, very distressing situation for them, because they are being exposed to loud noise on a daily basis, and now they are having tinnitus. And loud noise is the cause of tinnitus, and yet they need to expose themselves to that loud noise daily. So once you've taken this history, you go on to your quick maftosa. You go on to your ideas, concerns, and expectations, and then examination. As we discussed earlier, yesterday, for those who have joined us today, whenever you are doing an examination on the ear, you are always going to start with your observations, inspect from outside, feel from outside, and inspect inside with an otoscope, and do your hearing tests. Please do not miss doing the hearing tests. Again and again, I'm repeating, because this is something that can really help you a lot in management. So you tell the patient that I would like to do an examination on you, check your observations, checking your temperature and blood pressure especially, and then I'll just have a look and feel around your ear, feel for the glands in your neck. I'd like to have a look inside your ear with the help of an instrument called otoscope. Would that be all right with you? Yes, doctor, that's fine. And I'll also do some special tuning fork tests on your ear. Would that be all right? Yes, doctor, that's fine. If you want to name the tests, well and good. If you do not name them and just say Rennie's and Weber's, that's also fine. You say all these, and the examiner the patient might hand over the results to you that everything is normal. For example, everything is normal. This tinnitus might be due to the loud noise that he has in the environment. If you see wax in that particular area, particular ear, let's suppose one ear, it can be due to wax. If you find out any middle ear effusion, it can be due to that effusion. If you find that this patient has a unilateral sensory neural hearing loss, unilateral sensory neural hearing loss, then always think of acoustic neuroma. This is the red flag that I was talking about in the beginning. Okay, very clearly, if a patient is coming to you with a unilateral tinnitus and a unilateral sensory neural hearing loss, this is a hallmark of acoustic neuroma. So I feel that I've scattered it everywhere. So just now, to compile things once again, you took a good history. You rule out the red flags. The red flags are the weakness in one part of the face, or problems with vision or headaches. These are the red flags. Once you have done those, you go on to your examination. Once done the examination, you come to your management. Now it depends what you found in the whole history. If you find that the earwax is the cause, then remove the earwax, give him drops, send him home. see him after, tell him that usually the wax itself falls out once we use this olive oil drops or almond oil drops. If it doesn't happen, then please do come back to us. We'll again reassess you. If, for example, you find out that this patient has a sensory neural hearing loss in one ear, along with this one ear tinnitus, he says that I only have ringing sensation in one ear and sensory neural hearing loss also in one ear. Send him immediately. It's an immediate referral or a 2 weeks referral to the ENT specialist. Coming on to our next thing, which is unilateral hearing loss. Otherwise, if you do not, unilateral tinnitus, and there is no hearing loss, then again there's a red flag. What is the red flag? If the patient says that I have a pulsating sensation in my ear, he has a pulsating tinnitus, again this is a red flag. So when you're asking about the tinnitus history in the beginning, if he says it's a ringing sound, it's okay. If he says it's a buzzing sound, it's okay. You always verbally need to ask, have you ever felt that it's a pulsating sound? If he says yes, is it in one ear or both ears? It's in one ear. Please do send him to the ENT specialist, because it can be an AVM, arteriovenous malformation. All right, this is how it presents. Unilateral pulsating tinnitus. All right, so now coming to the case that is coming most commonly in our exam, the patient with bilateral tinnitus, and this patient is working in a music industry, and he is exposed to loud sound and noises every day. And now he's having trouble in sleeping, because at night, especially when it's silence, he is really hearing these ringing sounds a lot. This is what is written, the do's and don'ts in your NHS, very clearly. Ask him to relax himself, do some deep breathing exercises, some yoga. I'll share this picture in the group as well. So you ask, if he's unable to sleep because of this tinnitus, give him some sleep hygiene. The same things that we always give. Please try cutting down on your coffee intake, your cold drink intake, or your energy drinks before going to bedtime. Ask him to have a low background music at night, because whenever there is a very low background music, the patient's attention diverts and he doesn't feel the tinnitus very troubling. Right? So two things that that is something that is called a sound therapy as well. So we can do sound therapy for music therapy or sound therapy for this person. So this music that we are going to use as a therapy is not going to be loud. It should be very low background sound that is present in his background. Ask him to avoid, okay, what else is it written here? Try some self-help, like diverting his attention, self-help techniques, some books and stuff like that. And then offer him to go to support groups. It's very, very important. We do not take tinnitus that seriously, but tinnitus is very, very important because it can affect the mood of a person, and it is one of the very important causes of suicide as well. So please put that into your mind. Any patient coming to you with a tinnitus which you think is going to go a long way needs to be sent to some support groups and might need CBT as well. Please review this patient to see if he's coping well, or if he has any mood issues or anything like that. Okay? Do not have a total silence. This is a don't. Please do not have a total silence. Listening to soft music or sounds called sound therapy may distract you from the tinnitus. This is what we've already talked about. Do not focus on it, as this can make it worse. Yes, when they start focusing on the sounds, it can become worse. Actually, I've seen that whenever the patients who are coming to me in the general practice, when I deal with them, when I tell them to divert their attention, and sometimes they are having tinnitus. This has happened twice, that the patient was having tinnitus, and then I started asking him some important different questions that were of his interest. He completely forgot about the tinnitus. So distraction is very, very important. just like the tantrum cases. You ask him to distract himself. Do not think about or feel about the tinnitus a lot. This is all about our tinnitus case. Any questions will be taken in the end. Please keep writing them. I'll be more than happy to answer them. For now, let's go on for a 5 minutes break, and then we'll go on to our pediatric cases. We have 4 pediatric cases today, and then 3 hand cases as well. Let's see how much we are able to finish today. Right? So 5 minutes break, please. Thank you. Okay, let's start again. I'll answer all the questions that you have in the end. Do not worry, please. Inshallah. All right, let's start again. What do we have next? Temper tantrums. So before we go on to discuss the temper tantrums, let's discuss briefly or quickly the pediatric history. When a child is coming to us when a parent is coming to us with any issue that the child has, we always tend to, everybody knows that we always tend to follow a structure. Uh, Different people have different things in mind. The one that I use is BINDSMA, BINDSMMA. B is for birth, I is for immunization, N is for nutrition, D is for development, S is for psychosocial or the surroundings or the social, whatever you want to do. Even I put in smoking into that in the environment. And then MMA, any medical conditions, any medications, and any allergies. So BINDSMA history is very, very important, or birds, or whatever mnemonic you have in your mind, just use that. So the child is coming in with any problem, ask questions around the symptoms, always ask the BINDSMA history. Then you go on to do an examination on the child and give the management. Some of the red flags that you always do not want to miss in a child with fever, there's another mnemonic for that, PAMGU. If you want to use, that's okay, but if you do not want to use, it's more easier without the mnemonic, because P is for, okay, leave the mnemonic. Whenever a child is coming to you with a fever, just look for the causes of fever. First of all, meningitis, so any rash and any neck pain along with that, any ear pain, any pain in the throat, or any tummy pain, or any pain while passing urine. So this is very simple, very, very simple. Or any cough or shortness of breath the child has. This is in case of if the child has a fever along with other symptoms. So now we start with our case, temper tantrums. Where you are FI to working in the GP. Lisa James, age 30, is concerned about her 4-year-old daughter. Other information about the patient is none. What you must do, talk to her and address her concerns, and there is no special note. It can come as a telephonic station, or it can come as a face-to-face station. Mostly is a telephonic, just keep that in mind. You go in, you greet the patient. Hello, I'm Dr. XYZ working in this practice today. May I please ask your name? I'm Lisa James, age 30. How can I help you? I'm here to talk about my daughter. Can you please confirm the name and age of your daughter? My daughter is, let's suppose, Lucy, and she's 4 years old. All right, so how can I help you today? Doctor, I've been having a lot of trouble because of Lucy's behavior. She has not been the way she was before for the past few months now. She has been very cranky, very irritable. She tends to cry a lot and bang her head into the wall or onto the floor when I refuse to do anything. When I ask her to go to bed, she has problem with that as well. She doesn't want to go to the bed, and I need to smack her, push her, pull her to the bed and stuff like that. And then whenever she is sitting and eating, she sometimes tell you this whole story in one breath. Remember that, okay? So when she's eating food, she doesn't eat. She keeps playing with the food, playing around with her plate, sitting on the dining table. She is really being so uncooperative these days, doctor. I don't know what's wrong with her. I think she has some problem. Can you please tell me what I should do? You can see that this mother is very distressed. She is having trouble dealing with her child, always acknowledged from the beginning. I can see that. You seem to be going through a lot recently with Lucy's behavior. Can we talk about all the things one by one? Up till now, I have given this mock to many people, but some of the very important things, they have always been missed. I have never seen anybody asking around the history of presenting illness. We always straight away jump to the behavioral disorder and start asking the differentials. So please, when this mother is telling you all this long story, take that into account. Give that some importance. Ask some questions around that. All right, so talking about all these things one by one, can you tell me, uh, since she doesn't go to sleep when you want her to go, uh, how long does she sleep? Is she taking enough sleep or not? Yeah, doctor, she is taking enough sleep. I don't mean that she's not sleeping enough, but it's just that she disturbs a lot when she's going to sleep. Oh, all right, that's fine. And when she's playing with food, does she finish her food or not? Or she just leaves the food? So you are ruling out any nutritional deficiency or dehydration over here. Oh, no, doctor. She eats her food. She finishes it by the end of 1 hour, 1.5 hours, but she drags it too long actually. All right, and you told me that she has been having some issues whenever you ask her to do something or give her a command, she doesn't follow that. Is that right? Yes, doctor. So how do you react? Okay, reaction you can ask in the end. So you can ask her, uh, since when has this been happening for the past 4 months? Are all these issues increasing in the past 4 months? Yes, doctor. And what do you do when she behaves in this way? Doctor, sometimes I have to pull her to the bed. Sometimes I even need to smack her, stuff like that. All right. And any particular changes in Lisa's environment recently? No, doctor. Is she going to a nursing home or something? Nursery or something? No, doctor. Or yes, doctor. If she says yes, ask her any behavioral changes at the school or at the nursery at all. No, doctor. Everything is fine over there. So you're trying to rule out any problems that are present at two different places. Then you want to ask her. Start ruling out your differentials. Have you noticed that she responds to you when start with the hearing, vision, and speech? Sorry, always. These are the most common causes of having behavioral issues. Ask her when you talk to her, when you ask her to do something. Do you think that she listens to you? I just want to know that if she's able to hear well. Uh, does she speak well? Is her speech all right? Yes, doctor. And any vision problems at all? Have you noticed that she has any trouble reading stuff or anything like that? No, doctor. So speech, hearing, and what did I say? Third thing. So you need to rule out all these things. Then you go on to your next history. Ask her that have you felt that she plays with the same toys each time, and she stacks up her toys in a specific way, or she doesn't make an eye contact with others? Or have you felt that she is unable to stay in a queue, or she's unable to make friends or anything like that? Everything will be negative in the history. If it is a case of temper tantrums, everything is going to be negative. The only positive thing is going to be the problem that the mother has told you, and the problem in mother's behavior, not the behavior actually, the mother's way of dealing with the child when she does all this. So when you do go there, do ask her. You told me you smack her and you pull her to the bed. Have you ever tried rewarding her when she's behaving good? No, doctor, I don't think so. I think if I'll reward her, she's going to be even more bad. Okay, you go on to your bird's history or Bindesma history. How has her birth been, her immunization, her nutrition? You've already asked her nutrition in the beginning part. Do you think that she's developing just like other kids of her age? Okay, sorry, I completely forgot to say about the other siblings at home. You can ask that in that area or in the social history area. Ask her, do you have other kids as well, and how does she behave with them? Any problems, any sibling rivalries, stuff like that? Ask that history. Binds my history finished. You go on to say, if it's over the phone, just like always, ideally, if Lucy was in front of me, I would have examined her. But since we are on the phone, since we are on call, I'll just tell you what's going on. Okay. Well, it seems that she is throwing some temper tantrums. Do you have an idea what that is? Always have an interactive chat with the patient one, especially when it comes to your management part. Do you have an idea what that is? No, doctor. Well, sometimes children can have problem behavioral issues like this one. They have problem controlling their emotions or their temper in certain situations when, suppose, if they are not able to express themselves well, or sometimes when they want to gain something, then also they throw temper tantrums. This is something related to behavior, and this is something manageable as well. So please do not worry. I'll tell you how to manage all this. Give her give her some tips. Tell her that, please, whenever she is behaving in that way, like not taking food and taking some time to finish her food or not going to bed, try to avoid that situation. Do not again and again ask her to finish her food, because this is something called as negative attention. Whenever we give attention to a child, whenever we give attention to a child over something that should not be done, this is something called as negative attention. Okay, so tell her that do not again and again ask her to finish her food. Instead, distract her. Okay, avoid her or distract her somehow. So tell her to not smack the child. That is completely wrong. It will make her more stubborn and more unmanageable if you will do that. So please, Lisa, I highly advise you not to smack her, not to pull her to the bed. In fact, try to make her bedtime more nice, more comfortable, and more attractive if you want her to go to the bed, like putting on some good rhymes in her room, or maybe sitting with her and telling some rhymes yourself or some stories yourself. It means that the bedtime is not attractive for her. So try to make things, distract her from her present behavior and attract her towards something else that is more good. Give her red flags. What are the red flags? If you ever feel that she is not sleeping enough, she is not finishing her food, or you feel that she is not interacting with others, please do come back to us. Do come to us. I'll really want to assess her again then. Send her some leaflets through the NHS email if this patient is over the telephone. If she's in front of you, give her some leaflets. That's what you want to do. Tell her that if you have any other problem at any other time, please do let me know. I'll be more than happy to help you with that. That's all about temper tantrums, all right? So you've ruled out your differentials, you've taken a good history, you've managed the case well, and then you go on to your next patient. Your next patient is also a small child. Actually, the mother, you are FY2 in the GP, mother of a 3 years old child, Jason, is concerned about her son. Talk to her and address her concern. So there are two cases around this. I did not come up with two cases. So for today, I had an intention to discuss the one in which the mother is worried that her child might develop autism. Okay, so it's 2 years basically. MMR vaccine is given at this age. Oh no, 12 months. The 12 months old child. 12 months old child. Yeah, this one. So if you have this mother who is coming to you with a concern about MMR vaccine, you go in, greet the patient, confirm the details of the child and the mother, and start taking your history. Hello, I'm Dr. Noor, Dr. XYZ, one of the junior doctors working in this practice today. May I please confirm your name and age, the name and age of your child and stuff? How may I help you, doctor? I'm concerned about MMR vaccine. Okay. Can you tell me more about your concern? Well, doctor, I'm concerned that my child is due for her dose of MMR vaccine because she's 12 now, and 12 months now, 1 year now. So I'm really concerned that I've come to know that MMR vaccine causes autism. So I don't have much information about that. All right, thanks for coming in. I'm really glad that you came in to discuss this matter with me. So can you tell me, where did you get this information? First thing to ask, okay, you need to dissolve some of her ideas and some of the myths that she has in her mind. So ask her, where did you come to know about this? Doctor, I came to know from a friend, and also I read some articles on the internet and stuff like that. All right, Thanks for letting me know. And anything else? Anything else apart from this concern? No, doctor, I'm just concerned about this. All right, so let's talk about your child first. Is she up to date with her previous vaccinations? Yes or no? Yes, doctor. And have you seen any signs of autism her at present? Rule out your autism now. Okay, start taking a history. Ask her. She's just 12. So have you noticed any particular things in her, any behavioral issues up till now? Usually they are not evident at that young age, but do ask her a few questions. Do you think that she makes a good eye contact? Does she play with others? Just simple stuff like that. After asking that, you've already asked her about the immunizations, because the main concern is the immunization itself. Ask her, what do you know about MMR? Do you have an idea what MMR is? Well, doctor, I don't have much idea. All right, don't worry. I'll let you know about that as well. So now you have got two, three different things you've already asked her. You've asked her where did she gather the information about autism. You've asked her about any signs and symptoms of autism, a little bit in this one. And then you want to ask her about what does she know about the MMR. So you are still revolving around your question itself, okay? Autism and MMR. Then you ask her the birds questions, ask her all the birds history or the Bainsma history. Then you go on to do ask her if she has any other children or any family history of somebody having autism, just as a simple thing. After that, you go on to your examination. If the child is there, just generally examine her, see if the child is making any eye contact or not, do her observations for any fever or not. But this case is not coming with a child. It will never actually come with a child, because the mother is coming with a concern, so she won't bring the child in usually. You go on to your management part. So stepwise management is just addressing her concerns. Firstly, tell her that again, appreciate her for coming in today to know about autism, the relationship between autism and MMR. Let me clarify certain things for you, Mrs. Jason or whatever, Miss Lucy or whatever. Well, autism is actually not at all linked to MMR. Few years back, a research by one particular doctor misled the whole world about this thing. After that, many other researches were carried out, which very clearly showed that there is no relationship between MMR and autism, right? Many patients many people who have not vaccinated their children because of this myth, they have put their children at risk of developing MMR. So what is MMR? Measles, mumps, and rubella. 3 different bugs. So you've already told her that what other people are doing by following this myth. Then tell her the source of information that you have is not an authentic one. Internet is full of so much false information. So I would highly recommend you to use NHS links, patient.info whenever you need to look for an authentic information about anything. Okay, give her some leaflets right now. Then you go on to tell her, well, Mrs. X, MMR is measles, mumps, and rubella. These are 3 serious infections that once affect a child or an adult, anyone, can lead to very serious implications. Please do not start telling him the side effects of a vaccine and the side effects of blah blah. Tell her, try to convince her to do the vaccination for a child. That is what is being tested in this station. That is what you need to do in this station. Okay, convince her. How are you going to convince her? Tell her what are the bad effects of MMR, how it can present, what can be the life-threatening situations that a child can come across. Can have severe pneumonia, can have very bad rashes. The infection can travel to their brain and their spine, which can lead to lifelong problems, behavioral issues, lifelong weakness in a part of the body, and stuff like that. Tell her how serious these illnesses can be. But doctor, We do not see these problems in the community the way you are telling me. Yes, that's right, because we have already acquired herd immunity. Whenever more than 70% of the population is immunized with the vaccinations, they develop herd immunity. So the spread of the infections becomes very low. But at any point, if your child will come across a person who has who has traveled recently, or who has acquired this infection from a traveler, or from somewhere, from an unimmunized person, he can have this. Okay, and I've already told you how serious it can be. So I highly advise you to get your child vaccinated. Please do that as soon as possible. He or she is 12 months old. It's very important for you to keep up with the vaccinations. They can sometimes have very mild side effects, but they are just physical, like having a little bit of fever, or maybe very rarely, a little bit of rash. But they are very easily manageable just by giving paracetamol and just by giving some anti-allergic medication. Please do get your child vaccinated. When she will be vaccinated, we look for any signs of any other side effects, as we always do with other vaccinations as well, like your child has been receiving other vaccinations. Are you okay with this? Yes, doctor. Before she leaves, give her the red flags, because her child is not yet immunized and you don't know whether she's going to immunize her child or not. So give her red flags. So if you ever feel that your child has a fever, if you ever notice that your child has a fever, has a bad cough, or a rash on the body, please do come back to us. We might have to assess her. Give her some leaflets, some good links to the NHS website. Yes, that's all. Delayed walking. Next case, delayed walking and hemangioma. I think we'll only be able to finish up till this, or let's see. Delayed walking. You are FI2 in the GP. Jessica, mother of a 15-year-old boy and a girl, came to the clinic because of some concern. Can be a telephonic call or can be a face-to-face consultation. Talk to her, address her concerns, and discuss the plan of management with her. Children are not in the cubicle. So remember that whenever somebody is coming to you, what is walking? It's a part of development, right? So it's a part of your D in the birds or binds, whatever you're following. It's a part of the D in your birds. If a child is coming to you with delayed speech, that is also part of the D in your bird's history, right? So you are straight away starting with your D now, because the patient has come to you with a concern that is present, that is lying inside the D of the birds. You are FI2 working in the GP. The mother has come and she says that, doctor, I'm concerned because my child, one of the two children who are twins, one of these two children is not walking up till now without any support. Okay, he's not walking unsupported. So you start taking a history. I can see that you look concerned about your child. Can you tell me more about that? Yes, doctor. Well, is he, you told me that he's not walking, right? Yes, doctor. So is he walking with, so first, the history about unsupported walking, okay? So he's not walking at all. Has he ever walked unsupported even once? No, doctor. Does he stand unsupported? Yes or no? Does he walk with support? Yes or no? Does he stand with support? So you are gradually going back till the point you get a positive answer, okay? So if you're not clear, let me say it again in a more clear way. So in the normal development, what happens? The child first starts moving within the bed, then starts sitting with support, sitting without support, crawls, sometimes backwards, sometimes forwards, then starts standing with support, start standing without support, or start walking with support, or start walking without support. So since this patient has come to you with a complaint that the child is not walking without support, so you gradually start taking your history backwards. Okay, if he's not standing without support, does he walk with support or not? Does he stand with support or not? Does he crawl or not? Whenever you get a positive history, okay, yes, doctor, he stands without support, he stands with support or without support, that's okay. Stop your history of any problems like that over here. Ask him, have you noticed any problem with the leg? Does he limp when he starts with the support at all? Have you noticed any swelling at all? And any problems at birth when he was born? Because there can be a developmental dysplasia, right? So you ask all those questions to the mother. Once you have asked, then you go on to your other developmental history. You ask the history of these gross motor stuff. So you come to your fine motor stuff. Ask her, does he hold stuff with his hand? Does he hold his toys with his hand? And is he able to take the pen and try to write to something? He's 15 months old. Many a children do try and they may not be trying. So is he able to pick up things with one hand and take them into the other hand? So you are checking the hand grip and the pincer grip and stuff like that. Any other issues at all? Does he speak a few words or not? What about the other child as well? So okay, speak, eye contact, ask about any hearing issues. Does he look at you when you talk to him? So you are actually revolving your questions around the development itself. Then you ask this mother about the other child. Since you told me you had twin babies, what about the other child? Doctor, he is very well. He has even started running now at 15 months. Oh, that's really great to know. So what do you think is going on, Jessica? Well, doctor, I'm really concerned that there is something really serious going on because both of them were born together. And why is he not walking whereas she is walking? Okay, you know that she's are usually very fast and he's are many times a bit slow. So you need to reassure her, okay? After this history of development, you complete your binds. How was the birth? Is she up to date with her immunizations? Is she eating and drinking? Are they both? Ask about both of them. Are they both eating and drinking well? And any problems at home at all? Any other children that you have? Do you have enough support at home? Have they been? How was the heel prick test? It was done at 9 days of birth. Was that all right? So just ask those questions. Whenever it comes to medical history for a child, you can ask about heel prick test if you want to, because many of the conditions can be diagnosed there. Any allergies, blah, blah, blah. Okay, you go on to your examination. Usually, since it is over the phone, you can reassure her if everything looks fine. You can call her if you are not satisfied with it. Don't worry about calling the patient. If you feel that you're not sure whether there's any problem or not, call her. Call her with the child. Okay. Do an examination. Check the observations. Do the examination of the both legs. See if this patient has any visible weakness or muscular dystrophy or anything like that in one of the legs. Just have a look at that. Then see the child walking a little bit. In the history part, you also ask if the child walks with the support, if you hold the finger of the child, if he walks with you or not. Okay. Now you come on to the management. Reassure the mother. I can see that you're really, really worried about this whole situation. But it's a very normal thing for children at this age to develop their milestones at different ages. Okay, since you told me that your girl has started walking and your boy is still not walking, it is something very normal. I assessed him, and from the questions that you answered and from the examination that I did on him, I do not expect any problem to be there. There's an upper limit for each milestone to be achieved. In terms of walking, the upper limit is 18 months. So since he's 15, let's wait till 18 months and then see you again if there is any problem still. But I'll give you some tips which you can use to encourage him to walk. Okay, that will really be helpful. Please do not use any walkers. If you are using walkers, can be dangerous. Sometimes when they get unplugged from the bottom, they can really damage the legs of the child. Do not use any walkers. And sometimes the child can have a fall with the walkers as well. That's a bad one. Instead, use some totally forgot the toddle trucks. You can use some toddle trucks to help your child to walk. He'll just hold on the handles of the toddle truck, and the base of the toddle truck is really heavy, usually does not lead to a fall, and it will encourage the child to fall. Okay, it will make his leg muscles more active, and then he'll start walking more quickly. And also give him some tips like what he can do. Please try to stand in front of him, try to encourage him to walk, try to make him sit in front of you, and then you stand and encourage him to stand. Simple tips like that. I'll give you some reading materials about the tips that you can use to encourage your child to walk. But at any point, if you feel that he has a swelling in a joint and he has a fever and he's unable to walk with support as well, please come back to us. We are here to help you out. These are your red flags for this case, right? So take your consultations in a very safe way, in a very natural and good way. This is what is needed from us, from the safe doctors, right? Similarly, when it comes to speech, you can go around speech as well in the same way. Ask questions about speech and go on to manage that. Let's go to the next one. That's hemangioma. Birthmark. You are actually working in the GP. David, aged 1, has been brought in by his mother to you. Other information about the patient is none. Talk to her and address her concerns. She comes and tells you that, doctor, he has a mark on his, it can be anywhere. You know that birthmarks can be anywhere, and birthmarks are of different types. Okay, there can be some very mild patches that are there that go away after a while, after a few days or months, like the Salmon's patch, or just in the center of the forehead, the red patch. And sometimes it can be something like a hemangioma. So hemangioma, why are they giving this hemangioma only and not the other ones? Because this is one that can be something serious as well. So you start taking your history. How can I help you, doctor? I've noticed this mark on the leg of my baby. Okay, I've noticed this mark or this lesion or this swelling over the leg of my baby. Can you tell me a bit more about this swelling? So you do not know that this is a hemangioma. Just all that you know is that this is a birthmark or this is some lesion. You start taking your history. All right, can you tell me more about this mark? Exactly where is it, on the right or the left thigh? When did you notice it? Is it since birth, or have you noticed it now? Is it getting bigger? Have you noticed any bleeding or discharge? What's the site, size, shape, surface? All the things that we always take into account in terms of lesion. So site, size, shape, surface, consistency, any bleeding, any discharge from the surface, and if it gets stuck or entangled into the clothes. This is very, very important. Do ask all these questions. Have you noticed only one mark, or are there multiple marks on different parts of the body? Ask about all other health questions, your Bindsma history. Have you noticed any fever recently, any rashes on the body, his birth, immunization, nutrition, development, blah, blah, blah. The same thing again. To the examination. What do you see in the examination? This is what you see usually. This is what they are giving, and this is the most common appearance as well. A red colored raised capillary hemangioma is there. All right. See how deep looking it is, so clean and stuff. Not deep means into the skin. What I mean by deep is that it looks so sophisticated, sort of a lesion. So when you have a look at that, you already know that this is a hemangioma, a raised lesion, a red colored lesion that is there since birth, or sometimes even develops a bit after birth. You give her the diagnosis. So your child seems to be having a condition called capillary hemangioma. He seems to be having not a condition, a lesion called, or a birthmark called, don't say condition. If you say, don't worry, just a birthmark called capillary hemangioma. Have you ever heard about that? No, doctor. All right. So there can be different types of birthmarks, and this is one of them. Okay. This is basically a collection of blood vessels in a specific area. Usually it disappears by itself after some time, some months or couple of years. Please do not worry about it, because it's present on the leg and it's not troubling him at the moment. Since it's on the leg, you can ask him if any problem when applying the pamper. Do you think that it comes in the pamper line area or something like that? Because then it can bleed if that happens. So that's just a good history. That's just a part of good history. It's not that that's a matter of passing or failing. That's a part of good history that you ask her where exactly on the thigh it is. So once you're done with that, these are the red flags. I wrote them here. These are from the NHS website. Most birthmarks do not need treatment. They get better by themselves. They disappear by themselves. Can be removed if affecting. Can be removed. Oh, under the NHS subsidy. Okay, so can be removed under the NHS referral if affecting health, but not for cosmetic reasons. No cosmetic surgeries are being provided by the NHS, may it be for varicose veins, may it be for a mole, or may it be for a capillary hemangioma. So if it is affecting his life, what are the situations when it can affect the life? Sometimes this birthmark can be present, this capillary hemangioma can be present inside the lungs. So you need to ask the patient, the mother also, that if he has been having any cough or shortness of breath. Sometimes it can be present near the eye, nose, and mouth. These are also indications of referral, okay? Because eye, ear, eye, nose, and mouth, close to the sensitive areas, more prone to getting scratched and stuff. So you want to send this patient to the dermatologist as well. If worried about the birthmark, you can send. If the birthmark close to the eye, nose, and mouth, you need to send. If changed in shape, color, size, you need to send. If got bigger, darker, or lumpier, you need to send. If got sore or painful, then again you need to send. Okay, so if all these things happen, you need to send this patient to the dermatologist, or under all these conditions. Treatment options are medicines, laser surgery, laser therapy, and surgery. That's all. Nothing else for the treatment of this one. All right, in the comments box, if you guys can write down, if you want to continue with the session and also finish the remaining 3 cases, we can finish them if you guys want. Else, we can stop the session for now and go on to the question answer session. Please write in the comments box. Do not unmute your mic still. Continue. Need at least 4, 5, 6 more comments, please. Good. Oh, great. Everybody is ready to continue. That's good. With this speed, we'll be able to finish maybe even in less than 10 days, inshallah. All right, so let's continue with the session. Let's go to the next slide. Our next slide says, what's the next slide? It's Raynaud's phenomena, one of the very common ones coming these days, and maybe a confusion as well for a few people, few doctors. So you are FI2 working in the GP. Who the patient is? Zach, aged 26, has come to you with a complaint in the fingers. Other information about the patient is none, and what you must do, talk to him and address his concerns. What is Raynaud's phenomena? It's a phenomena which can be primary or it can be secondary. Primary Raynaud's phenomena is something you can suspect if the patient is coming to you under the age of 30 and you do not find any other signs and symptoms of autoimmune diseases in this patient. Okay, so I'm just giving you an overview first, and then we'll go on to see how we need to deal with this patient. So you need to know that anybody who is less than 30 years in age is coming to you with swollen, painful hands. You definitely at any age need to ask the autoimmune disease symptoms, but always keep in mind that most likely, many a times, it is just a primary Raynaud's phenomena which does not have any cause, and it resolves by itself gradually with the passage of time and age. Okay, anybody over the age of 30 coming to you with Raynaud's phenomena, swelling and pain in the hands. Yes, you need to think of autoimmune problems. Okay, but anyways, whether it's above 30 or below 30, you are a safe doctor, so you are going to take a complete history. Start taking your history. Hi, I'm Dr. XYZ, one of the doctors working in this practice. How can I help you, doctor? I'm having this pain in my hands for the past few days or weeks, something. He can say anything. He can be coming to you after a few days or weeks. All right, can you tell me more about this pain? Yes, doctor, it started suddenly. It's gradually increasing with the passage of time, and it's really affecting me a lot. I'm really sorry to hear about that. Can you tell me exactly where is the pain? It's in all my fingers. Is it in one hand or both hands? Yes, it's in both the hands and all the fingers of both the hands. All right, so you have already caught that it's in all the fingers, because one finger is a red flag. Remember again, okay? One finger is a red flag. You need to look into autoimmune causes and other sinister issues that can be going on. So both the hands, all fingers. What about feet? Any problem with your feet? No, doctor, no problem with the feet. All right, since when have you been having? Since the past 2 weeks. Have you done anything to make it better? Anything to make it worse? Is it getting worse with the passage of time? On a scale of 1 to 10, how would you grade your pain? Blah, 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 all those questions. Once you've asked all those, have you noticed any swelling as well? Any stiffness in your fingers in the morning at all? Have you had trouble working? What do you work as? Doctor, I need to work in the cold, even need to bicycle every day. He's a delivery person, or he's working in the ice somewhere. So he's being exposed to cold a lot. Okay, so you are actually trying to check that what this patient is working as, just to find out if he is working in cold or not. He tells you that's the reason his work is being affected. So you start asking him other questions. Have you noticed that this becomes more worse when you are cold, when you are in cold environment? Anything that makes it better? He might tell you that I feel better a bit better when I'm at home, or a bit better when I'm in a colder, in a warmer environment, or a bit better when I'm wearing gloves, or something like that. He might tell you, or he might not tell you anything. But this is what, these are the possible answers from the patient. So you've already explored your pain history. You've already explored your occupation, your patient's occupation. Now you go on to your differentials. Okay, apart from this, have you noticed any fever recently? Have you noticed any pain in your different joints of the body? Have you noticed any rashes on your body? Have you noticed any vision problems? Have you noticed any pain in your back? Have you noticed any changes in your bowel? Do ask all these questions. These are not a lot. These are just 4, 5, 6 questions. You are showing your examiner, and you are being a safe doctor. So be a safe doctor. Ask all these questions. Go to your meftosa. Family history is very, very important in terms of your autoimmune diseases. Ask him any medication, any medical conditions that he has. You'll come to know if he has already been diagnosed with any autoimmune conditions or not. Then you ask him about any medications. Sometimes some medications that lead to vasoconstriction can be troublesome, along with if the patient already has a problem. Then, like beta blockers, then you go on to your family history. Then you go on to your SNAPS history: smoking, nutrition, alcohol, physical exercise, and stress. Smoking, nutrition, alcohol, physical exercise, and stress. Once you've taken this history, if you come to know that this patient is smoking, you need to stop him from smoking. That's a risk factor for worsening his symptoms, and otherwise as well, that's not good for health. So you have taken your history now, you go to your examination. Okay, ICE is very important in all the 16 stations of your GMC exam. Do you have an idea what could be the cause? Do you have any particular concerns about it? Any particular expectations from us today? Examination, I'd just like to have a look at your hands. Before that, I'll check your observations, especially your blood pressure, temperature. and then I'll go on to your hand examination. I'll also examine your skin and your joints to make sure everything is fine. Do a hand examination. I'll look, feel, and ask you to move your hands in different directions, blah, blah, blah. They might give you a picture of swollen hands. I'm sorry, I forgot to paste the picture here, but you guys can just Google it and get to see a picture of Raynaud's phenomena. All fingers, both hands, primary Raynaud below 30, no other symptoms. Okay, so when you get to know that this patient is 26 years old, he has come with this presentation, you start with your Qasim RRR. Thanks for coming in today. From the information that you've given me and from the examination that I did on you, it seems that you have a condition called Raynaud's disease. Have you ever heard about that? No, doctor. Primary, don't say primary, just say Raynaud's disease, because you yet have to confirm that this is primary by doing the investigation. So tell him that it's a condition in which due to cold weather and due to certain other environmental triggers like smoking, the patients can have a narrowing of the blood vessels in the fingers and can lead to pain because of decreased blood supply. Are you with me? Do you want me to repeat this? I'm sorry for this long sentence. Okay, there can be some narrowing in the fingers, narrowing of the blood vessels in the fingers due to certain things in the environment like cold weather, smoking, some medications and stuff like that. Okay, but please do not worry, it's a manageable condition, but I would highly advise you not to expose your hands to cold weather. If he's working in the cold weather, give him a note to show to his employer, which can state that he should not be working in a cold weather because he has pain due to this problem. And if you can change his position or something like that, first ask him to talk to his employer himself. Always, whenever it comes to employer, always encourage the patient to talk to his employer first. If not, you send a note to the employer. If not, then you give other options. Okay. So once you've talked about that, tell him that I can give you some medication as well. But before that, if you would like to try some strategies like keeping your hands warm with the help of some gloves, you can wear some warm gloves, not the thin gloves. Wear some warm gloves, especially while going out. You can even wear double gloves. The more the warmth, the better it would be for your pain and for your symptoms of swelling as well. There is a medication present. If you want, I can give you that. Many a times the patient might say that, okay, let me try without the medication and then get back to you in a week's time. That's the best thing. That is the best thing for you as well to offer. If he comes back, give him a calcium channel blocker that helps in relieving his symptoms. That's all in this case that you need to do. Then you go on to your what else do we need to do? Oh, sorry, investigations. Sorry, Qasim RRR. I'm distracted a little bit. So Qasim RRR, you told him about the Raynaud's phenomena. You tell him that I'll involve my senior. He'll also have a look at your hands, and we can send for some baseline and some special tests. Baseline and ANA. That's all. Don't send for the whole big ENA profile. You just need to send for ANA. That's all. If ANA is positive, then you can go ahead from there. Then give him all these medication strategies, the tips to avoid having the swelling in fever, swelling and pain in the hands. Go on to your triple R's, give him the red flags. If you ever feel that you have pain in only one finger, or if you feel that you also have a rash on the body or joint pain or vision problems or backache, please do come back to us. We might need to reassess you for that. Give him some reading material about Raynaud's phenomena and also review this patient after 2 weeks' time to see if there is an improvement. 2 weeks or 1 week or whenever his blood reports are ready, just review him. Okay. De Quervain stenosynovitis. All right, very easy one. Let's go for carpal tunnel first, because once you cover carpal tunnel, this becomes very easy. Carpal tunnel syndrome. You are FI2 working in the GP, who the patient is 40 years old. Sophia has come in to see you for pain in her hand. So all these 3 cases are for hand pain. See how common is a hand pain, a problem in the community. What you must do, talk to her and and manage her. Okay, so you go in, you start taking the history. Hi, I'm Dr. XYZ working in this practice today. How can I help you, doctor? I have pain in my hand. Can you tell me more about this? The patient might not point towards the hand now, might say towards the wrist. Okay, so you always need to clarify whether it's in the hand, it's in the fingers, or it is in the wrist. So when you ask her, she says that she might say that because this is how it happens in carpal tunnel syndrome. The pain is in the wrist as well as in the hand. More on one side, that is on your lateral side, in the thumb, in the index finger, and in the middle finger. Okay, the distribution of the median nerve basically. So you start taking your history. Since when have you had this pain? Is it continuously there, or does it come and go any particular time of the day when the pain is there? The time is usually at night. The pain is worse. You okay? Give me a moment, please. Give me a moment, please. Hello, I'm sorry. I'm really sorry for this. I'm back. All right, so you start asking the pain history. You take a complete pain history, the Socrates. After that, you go on to ask this patient that apart from this pain, have you had any tingling and numbness in your fingers? Yes, doctor, I do have some tingling and numbness in my fingers as well. Can you tell me, have you which fingers are they? Usually in the lateral 3.5 fingers, she should be having all the symptoms in. Then pain in the wrist, you ask whenever it's a hand pain, please do go above as well. Do go to the elbow, do go to the shoulder or to the neck as well. Always do not miss on this, because you have no idea whether these symptoms are coming from impingement of the nerve up in the neck or in the elbow or at hand. Okay, do ask any pain or tingling or numbness in your upper part of the arm, or any pain in your elbow joint, or any pain in your neck. These three simple questions will make you a safe doctor. So do ask that as well once you're covering your pain area. So you come to know that this patient just has this pain and tingling and numbness and stuff in her hands, not above in the cervical region or in the elbow. You go on to ask further questions. Any stiffness along with this? You want to be a safe doctor. She is 40 years old. She might be having some rheumatoid arthritis or something like that. So do ask her any stiffness, early morning stiffness in the hands. No, doctor. So this pain is more at night. Yes, doctor. So what do you do to relieve this pain? Doctor, whenever I shake my hands, the pain goes away. All right. So you got your diagnosis. Always patient complaining of hand pain, which disappears or becomes better by shaking. Always think of carpal tunnel syndrome. Whenever you have identified that it could be carpal tunnel syndrome, there are certain reasons which can lead to carpal tunnel syndrome. Anything that can lead to accumulation of fluids in the body can lead to carpal tunnel syndrome. So start asking her. I mean, about any recent pregnancies. Ask her that does she have any weather preferences? Just a few questions. If you want to ask that in the history, all right. Else, I prefer to ask that not in the history but in Meftosa. Have you ever been diagnosed with any medical conditions like Thyroid issues, hypothyroidism, or any other problems at all? No, doctor. And any heart related issues? No, doctor. Have you ever been pregnant? Yes, doctor. When was the last pregnancy? She might tell you, I just delivered a baby. Okay, so you just ask all those questions, or to be a safe doctor. And do you use your hand regularly into something? I just do my daily routine works. And does it affect your life? He may say yes, he may say no. Usually these patients have problem at night. You complete your maftosa, you complete your DESA, you complete your history of eyes, ideas, concerns, and expectations, and then you go on to your management. Management is very, very simple. It's almost the same in this one and in de Quervain stenosynovitis. Not much different. You can always give them some painkiller. Okay. Remember that in carpal tunnel syndrome, never ever give your NSAIDs. Okay. In NHS patient info, if I'm not wrong, I read it once. They've written NSAIDs. I was really astonished to hear that, because NSAIDs are never given in a case where you are suspecting that this patient has carpal tunnel syndrome. Why? Because NSAIDs lead to accumulation of fluids. That is the reason we do not give NSAIDs in patients with heart failure or heart issues, right? So when I rechecked that in CKS it was clearly written that you should not be giving NSAIDs to the patients, right? So to be more clear, repeating it again, please do not give NSAIDs to your patient who has carpal tunnel syndrome. You can give NSAIDs to patients who have de Quervain stenosynovitis, but not carpal tunnel. Okay, so go to your management part. With Qasim RRR, you seem to be having a condition called carpal tunnel syndrome. Do you have an idea what that is? Oh, sorry. Yes. Sorry, Dr. Rubina. Thanks for reminding. I didn't go to the examination at all. Straight away went to the management. So examination is very, very important here. So you go to the examination, examine the patient's hand, check the observations, to the examination, and in the examination, yes, Tinel and Fallon test is very, very important. One of them is usually, it is a clinical diagnosis. Around 99% of the cases, when you do this Tinel or Fallon test, any one of them will be positive. So you tell the patient, I'll just check your observations, do an examination of your hands. In the hands, I'll just look, feel, and move your hands. And I'll also do some special tests called as the Tinel and the Fallon's test. When you do one of them is positive, so now you've confirmed your diagnosis and you go on to the management part. In the management, you explain the condition to the patient. You seem to be having a condition, carpal tunnel syndrome. It's a condition in which sometimes there can be, there's a thin band that is running across your wrist. Sometimes it can get tightened due to certain reasons and can give symptoms like yours: tingling, numbness, and pain in the thumb, index finger, and the middle finger. All right, but please do not worry; it's a manageable condition. What I can do for you now is that I'll give you some painkiller like paracetamol, or give him cocodamol to be used, not NSAIDs. Then you also do some investigations. What investigations? Just for TSH levels, all the baseline investigations and the TSH levels. Then you go on to give this patient some rest. Ask, what are you going to give for the rest purpose? Give this patient wrist brace. Tell her that she needs to use it regularly, especially at night. This wrist brace is going to keep your wrist straight, and it will prevent this pain and numbness at night. Tell her that many a times, just by using the wrist brace or the hand brace, the patients get a complete relief from the symptoms, just with paracetamol and wrist brace. If it does not get better, please do come back to us. We might need to send you for some physiotherapy of the hand. If still not, please do come back to us. There are other options as well, like giving some steroids into your wrist and then the ultimate resolution is the surgery. Okay, so this is what you need to tell her in a stepwise manner. If she says that, doctor, what if it doesn't get better? Then we have other options. We can send you for some physiotherapy. We can also send you for some steroids injection into your wrist, and we do have an option of surgery as well. Give her the red flags. If you feel that you have swelling in one of the hand joints and you have fever or you are unable to move your hand, please do come back to us. Septic arthritis, red flag, okay? To come back to us. Give her some reading material and give her all the information that she needs. That's all in carpal tunnel syndrome. Coming back to dequer vein tenosynovitis, your FI2 working in GP Victoria, aged 42, came to you with pain in the hand. Talk to her and address her concerns. This is almost the same, but the pain is at a different location. It is on the lateral part of the lower part of your arm, actually, the forearm. And this patient might sometimes say that the pain is going till my thumb. So because it is in the base of the thumb, the pain is at the base of the thumb. The patient will point at the pain with one finger, that the pain is here. Sometimes on the lower part of the lateral part of the wrist, the pain can be there. So just to clarify more, the pain can be here. If you guys can see me, here in this part of the wrist, okay, the lateral part of the hand, the base of the thumb, or this part of the wrist here, okay. So the tendon here that is being affected will cause the pain. So once you've clarified where the pain is, you start taking your history, the pain history. Socrates, ask everything. There will be no tingling, no numbness, no nothing at all. The pain is just here. You ask her about what type of work she does. She'll tell you, and you usually will find out that this patient is either picking up something in routine, like the patients who are postpartum can have this pain. The patients who are doing some repeated dealing with some vibrating tools or doing some repeated hand movement activity can have this type of pain. Sometimes the ones who are working over the laptop and then they bend their hands in specific way, they can have this pain. So you ask her about the occupation, you take the maftosa history, you already know it is a clinical diagnosis, so you need to be able to diagnose it clinically. Once you've diagnosed it, you've taken the history, you do the examination, check the observations, do a complete hand examination. Whenever it comes to hand cases, don't think that, okay, this is dequer vein, so I'm only going to go and do the Finkelstein test. No, you need to say either look, feel, and move your hands around, and also do some special test called as the Finkelstein test. If you are confused whether this is carpal tunnel or Finkelstein, be smart, do all the three of tests. If the examiner gives you a finding, the patient gives you a finding that the Finkelstein test is positive, you now know that this is dequer vein tenosynovitis. If the examiner says, or the patient says that hands over the result of the examination to you and saying that the Fallon's or the Tinel's test are positive, then you know that this is carpal tunnel syndrome. You want to manage your patient almost exactly in the same way as you did previously. Here, in addition to the painkillers, to the rest is very, very important. For that, you always you stabilize the finger with a brace as well. Okay, the hand with a brace as well. You need to stabilize the thumb actually. Okay, so thumb brace is present separately for this purpose. Wrist brace, thumb brace, they can be used to stabilize the thumb. Because we need to prevent that repeated hand movement, and we need to prevent that vibrating, dealing with those vibrating tools. So advise her not to use any vibrating tools, not to do any repeated hand movements with her, that particular hand especially. Give her some painkillers, give her some rest. So use the price, PRICE, price in this case. P is painkiller, R is rest, and ICE is ice application. Okay, P is painkiller, R is rest, rest from using those tools and rest from the activities, rest by giving her the brace. And ice is the ice application. Ice, how are you going to tell her? Tell her that you can just take up some frozen peas or something like that, and then apply, fold that into a towel or a cloth and apply that over your wrist 2 to 3 times a day, over the base of her thumb 2 to 3 times a day. It will really help you a lot with your symptoms. It's a self-limiting condition. She does not need any long-term treatment or stuff like that. If it doesn't get better, then again steroid, and still doesn't get better, again surgery. Just like carpal tunnel syndrome, you're going to end up this case. All right, I hope we have finished now. So I'll take a moment and we'll start with the question answer session.